Imagine witnessing a cancer that was supposed to be unbeatable vanish entirely after a targeted treatment. Could this signal a game-changer for those battling rare soft tissue tumors? That's the astonishing reality in a groundbreaking case study involving Pembrolizumab, which led to a complete pathological response in a patient with recurring dedifferentiated liposarcoma, DDLPS. Let's unpack this fascinating report step by step, exploring what it means for patients and the medical community, while I guide you through the details in a way that's easy to follow, even if you're new to oncology terms. And here's where it gets controversial. Could high tumor mutational burden really predict success with immune therapies? Or is there more to the story? Stick around as we dive deeper. You might be surprised by the implications. First off, for those unfamiliar, dedifferentiated liposarcoma, DDLPS, is a rare and aggressive type of cancer that starts in fat cells, but loses its original structure, making it harder to treat. This patient stood out as an exceptional example, not just for his DDLPS diagnosis, but also because his tumor displayed a high tumor mutational burden, TMB. To simplify, TMB measures the number of genetic mutations in a tumor's DNA. Think of it as a count of errors in the cancer's blueprint. A high TMB often means the tumor might be more vulnerable to the body's immune system, potentially making it respond better to certain drugs. Additionally, the tumor microenvironment, TME, the surrounding area packed with immune cells and other elements, showed a dense presence of tumor-associated macrophages, TAMs, which are immune cells that can either help or hinder the fight against cancer. This case report suggests that both a high TMB and abundant TAMs in the TME could serve as reliable indicators for a positive reaction to immune checkpoint inhibitors, ICIs, those innovative drugs that unleash the immune system to attack cancer cells. Published in the World Journal of Surgical Oncology, this report details what experts believe is the first documented instance of a patient with recurrent retroperitoneal DDLPS achieving a pathological complete response (pCR) to pembrolizumab, also known as Keytruda. For beginners, pCR means no detectable cancer cells remain after treatment, often confirmed by examining tissue under a microscope. It's like the ultimate win in cancer therapy. The lead author, Shun Abe, MD, PhD, from Japan's Niigata University Graduate School of Medical and Dental Sciences, and his team shared this remarkable experience, emphasizing how tumors in retroperitoneal DDLPS, located in the space behind the abdominal cavity, tend to grow quite large before diagnosis. Consequently, the main curative approach involves surgically removing the tumor along with nearby organs and tissues, but as Abe and colleagues pointed out, recurrence hits hard, affecting up to 83.2% of patients. This high relapse rate, backed by studies in the Journal of the American College of Surgeons, paints a grim picture. Recurrent or advanced cases of retroperitoneal DDLPS, like other soft tissue sarcomas, STS, carry a poor outlook with few viable treatment paths. But here's the part most people miss. Emerging data hints that some DDLPS patients might actually benefit from ICI therapies, sparking debate over why certain tumors respond while others do not. Now, let's meet the patient at the heart of this story, a 73-year-old man already managing prostate cancer with hormone therapy, which had spread to his lungs and bones. During routine scans for his prostate condition, doctors spotted a complex, multilobulated tumor in his right iliac fossa, a region near the hip. He underwent surgery to remove it completely, but just 8 months later, the cancer returned with widespread peritoneal dissemination, meaning it had spread throughout the lining of the abdomen. Standard treatments followed: doxorubicin, a chemotherapy drug, pazopanib, a targeted agent that blocks blood vessel growth to starve tumors, and eribulin, another chemotherapy option. Unfortunately, his lesions kept progressing despite these efforts. That's when genetic testing revealed a high TMB of 13 mutations per megabase in the original tumor, prompting his medical team to try pembrolizumab at 400 mg every 6 weeks. The results were promising. A partial response with target lesions shrinking by 56.7%. However, the therapy triggered a severe side effect, grade 3 inflammatory arthritis, an autoimmune reaction that caused significant joint inflammation, leading to the drug's discontinuation. Undeterred, the patient proceeded to a second major surgery, where 9 disseminated lesions were excised. Histological analysis afterward confirmed something extraordinary: a full pathological complete response, marked by widespread hyalinization, a glassy, scar-like change in tissue, and necrosis, cell death, with no living cancer cells left behind. 15 months after that second operation, the patient was still alive and free of disease, a testament to the potential of this approach. As Abe and his colleagues noted, this case underscores the possible effectiveness of ICIs for a select group of DDLPS patients and offers crucial clues about biomarkers that might forecast success with these treatments. Soft tissue sarcomas are often dubbed immune cold due to their low immune activity and typically low TMB levels, where fewer than 10% of patients might have a high TMB, 10 or more mutations per megabase. The rarity of high TMB cases in STS complicates research, but this report proposes a possible link between elevated TMB and ICI responsiveness in DDLPS. Yet, not everything is straightforward. Here's where it gets controversial again. The study authors admitted a key limitation: the TME wasn't examined until after pembrolizumab treatment, which might skew the findings. Moreover, it's conceivable that the prior use of doxorubicin could have primed the TME, making it more receptive to ICIs, as supported by research in cancer immunology research showing how chemotherapy can enhance immune responses. This raises eyebrows. Should doxorubicin be used deliberately before ICIs to boost outcomes, or is this just coincidence? And with DDLPS generally having low TMB, does this case mean we should rethink screening for high TMB subsets in all sarcoma patients? Overall, the investigators stress that further studies are essential to identify which DDLPS patients could truly thrive on ICIs. Our findings highlight the necessity of improving predictive biomarkers for ICI responses in this cancer type through upcoming research, they concluded. By expanding on these ideas, we can see that while this is just one case, it opens doors to personalized medicine, potentially saving lives by tailoring treatments to individual tumor profiles. For instance, imagine more patients getting genetic profiling early on, leading to faster ICI trials instead of exhausting other options first. What do you think? Is this enough evidence to prioritize ICIs over standard chemotherapies for recurrent DDLPS, especially in high TMB cases? Or do you disagree that prior chemo like doxorubicin plays a priming role? Could it be risky to combine them? Do you believe immunotherapy represents the future for all soft tissue cancers, or is it overhyped? Share your opinions, agreements, or counterpoints in the comments below. We'd love to hear your take and spark a conversation on this evolving field. References: Abe S., Ju Q., Arizuma T. et al. Pathological complete response to pembrolizumab in recurrent retroperitoneal dedifferentiated liposarcoma with high tumor mutational burden, a case report. World J. Serg Oncol. 2025, 23, 1449. doi, 10.1186 S12957-025-04096-3. Kung Ez, Hornick JL, Bertagnoli MM, Baldini EH, Rout CP, Predictors of Outcomes in Patients with Primary Retroperitoneal Dedifferentiated Liposarcoma, Undergoing Surgery. JM Col Serg, 2014, 218, 2206-217. doi, 10.1016, j.jamkelserg.2013.10.009. Zhu MMT, Shinasa E., Nielsen T.O. Sarcomas, Immune Biomarker Expression and Checkpoint Inhibitor Trials. Cancer Treat Reverend 2020, 91:102115. doi, 10.1016, j.ctrv.2020.102115.